The beginning of September, we're back to face-to-face CPD. We have a session on respiratory health, and we look forward to welcoming you there. If you're not in receipt of our monthly newsletter, it's about to be released for the month of September, and this will contain all of the details of our upcoming events. We're also, at this time, I'd like to welcome our viewers on YouTube. Throughout the session today, we'll be hoping for your interaction, so please do post your questions in the chat. If you'd like to verbalize your question, then raise your hand and we will unmute you. Similarly, if you're joining on YouTube, please jot down your questions on the YouTube chat, and we'll put those to Mr. Shahrad Dr. Shahrad at appropriate pauses during the event. Today, moderating the event, we have Ms. Joyce Ma'awad, and I'm going to now pass the microphone over to Ms. Joyce, who will introduce today's event and our speaker. Thank you, everybody.
Good evening. Thank you, Dr. Zach. You're welcome, everybody, to attend this workshop answering your questions on childhood obesity from diagnosis to management. This webinar will be provided by Professor Shahrat Tahiri, who is a senior consultant physician in diabetes and endocrinology at the National Obesity Treatment Center at Hamad Medical Corporation. He has been a member of the National Diabetes Strategy Committee and chairs the Research Committee for the National Diabetes Strategy at the Ministry of Public Health in Qatar. He has contributed to several of Qatar's national guidelines, including the Guideline on Obesity. He has been instrumental in the setup and development of the National Obesity Treatment Center. Professor Tahiri's research was one of the first to show that sleep duration is associated with obesity, increasing recognition of sleep as an important lifestyle factor. Recently, his internationally acclaimed research in Qatar and the first clinical trial aiming at reversing diabetes in the Middle East showed that it is possible to reverse type 2 diabetes in a significant number of patients through intensive lifestyle intervention. Professor Tahiri has over 20 years' experience in managing people with obesity and bariatric surgery, and led the largest obesity center in the UK National Health Service before coming to Qatar in 2013 as Professor of Medicine at Weill Cornell Medical College in Qatar. He has been a member of the Clinical Care Committee of the World Obesity Federation and is on the editorial board of leading obesity journals. You're welcome, Dr. Tahiri, and thank you for accepting our invitation to share your expertise in this interesting topic. The floor is yours.
Well, thank you for being invited for that introduction as well. It's been excellent to be talking to you about this very important topic. The topic is fairly vast, so and there are conferences on the topic, so I'm going to summarize for you various questions that potentially come up in terms of childhood obesity. So we're going to present early risk factors for childhood obesity and discuss them and how we measure obesity, discuss the nutritional management of physical fitness recommendations for childhood obesity, talk about complications of obesity, and also mention some local strategies that are ongoing. I thought I'd share a video with you to put everything into context about how childhood obesity happens. So hopefully this will work.
This is Aisha. When she was young, she felt invincible. She thought she could do anything she wanted. She was intelligent, always did well at school, and ate whatever was cooked for her at home. She thought nothing bad could happen to her. Aisha didn't like vegetables, but she did love fruit juice. She drank it all the time and thought it was healthy. But she barely drank any water. It didn't taste as exciting as juice. After school, she would relax in front of the TV or play on her computer while snacking on crisps and biscuits. And when she was under stress or had argued with her parents or siblings, she would eat chocolate to make herself feel better. Some girls at school made comments about Aisha's weight, but people who mattered to Aisha had bodies similar to hers, so she tried not to let the bullies bother her. Aisha didn't feel fit and began struggling with shortness of breath when walking. It started to be easier to just hang out in the playground chatting rather than playing games. As she got older, she started finding it harder to find her sizes in stores and wished she could wear the dresses she saw on the mannequins. When Aisha went to college, she was studying so much that she barely had any time to pay attention to her health. When she did have time, she would go out for coffee with her friends and treat herself to a chocolate muffin or a pastry. Aisha met someone, and they decided to get married. She wanted to lose some weight before her wedding and went on a strict diet. She lost a lot of weight and was very happy with the results and the way it made her feel. However, after getting married, she struggled to keep up with the intense demands of the diet and quickly put back on the weight she'd lost. Aisha and her husband wanted to have a baby, but after making many attempts, they could not conceive. They went to see a specialist who said that Aisha's weight may be contributing to their inability to succeed with pregnancy. Eventually, Aisha and her husband became pregnant through in vitro fertilization. As the pregnancy progressed, Aisha felt increasingly more short of breath than usual. Her blood sugars also rocketed up, along with her blood pressure, and she was diagnosed with gestational diabetes, forcing her to take tablets and insulin to control her blood sugar levels. Doctors were concerned for the health of the baby and recommended delivery via cesarean section. The recovery post-cesarean section was long and difficult, largely in part to Aisha's weight. The same issues returned when Aisha became pregnant a second time. However, this time, she was diagnosed with type 2 diabetes after giving birth and had to start regular medication. Doctors asked Aisha to monitor her eyes, kidneys, and feet because diabetes can result in blindness, kidney failure, and amputations. She also had to take regular blood pressure medication and cholesterol pills. Aisha's weight was now a threat to her health, and she decided to try losing weight. She tried several diets, and although some of them resulted in weight loss, it was unsustainable. She sought out help from dietitians, but they never seemed to understand her problems. She tried to go to the gym, but she struggled to stay motivated and was too busy looking after her children to find time regularly. Doctors told Aisha that her kidneys were failing due to her diabetes and high blood pressure, and now that she needed dialysis 3 times a week. This made Aisha unbearably tired, and she felt unwell most of the time. She had to turn to her daughter in hopes that she could donate a kidney, but doctors said that she could not have the transplant yet, as both her and her daughter's weight were too high. When Aisha was young, she felt invincible. How could Aisha have changed her story?
As you can see, Aisha's story is a very common story that we see in the clinic with childhood obesity starting. So in a way, it puts into picture how human life is affected throughout the course with obesity. So we're going to talk about measurement of obesity, prevalence of childhood obesity in the region, factors contributing to obesity in children, consequences of childhood obesity, and potential treatments. So what is obesity? It's now accepted that obesity is a disease that has to be managed. And it tends to be a lifelong disease for most people who are affected by this. It's 3 things: having too much fat, adipose tissue in the body, it's having fat in the wrong place, which is around the visceral organs, such as the liver and pancreas, and that results in complications such as diabetes and cardiovascular disease. And also fat that is sick and inflamed adipose tissue is what results in all the complications that we see in terms of obesity. We usually measure it using the body mass index, which is weight over height squared in kilogram and meters, but it's an indirect measure of body fat. And most of the ways that we can measure body fat are fairly invasive. The gold standard is a DEXA scan that is used in the clinic, which is an X-ray that requires some element of radiation. But other measures that we use especially in younger children, will be the weight-length ratio. We can also look at the weight circumference, and also look at the weight-height ratio as well. Now, body mass index is convenient to look at the population, but it's not going to be the exact measure that we need to. And in children, it's particularly a problem because they're growing. So we need to use specific standards for measuring obesity in children. So this is BMI. So in adults, you can see there are different classes of obesity. There's overweight is 25 to 30. But I have to say in the Asian population, 23 is the cut point, and 27 for obesity in Asian groups. So in terms of children, we need to look at the growth standards. So WHO recommends using growth standards birth to 5 years, and the BMI of 3 standard deviations above the growth standard median is considered to be obese, and 2 standard deviations is considered overweight. And for those children aged 5 to 19 years, there's a BMI of 2 standard deviation above the WHO growth standard for obese, and 1 standard deviation above the growth standard for overweight. CDC has got different criteria. They use the CDC growth chart, looking at children 2 to 19 years. BMI is assessed by age and specific percentile. So somebody with obesity will have a BMI of greater than 95%, 95th percentile, and overweight is between 85 and 95th percentile. In those who are from birth to 2 years, they use the CDC uses the WHO criteria to measure obesity. So here you can see the CDC, the growth chart here. You can see this child is 14 and a half years old with a weight of 70 kilos and a height of 152 with a BMI of 30 kilograms. Is very high on this centile chart, and greater 120% of the 95th, which suggests that there's extreme obesity going on here. The International Obesity Task Force, which is part of the World Obesity Federation, provides different BMI cut points that match the adult cut points from BMI of 25 to 30 for children aged 2 to 18 years. So we have several different ways of measuring obesity. It's important to be consistent in terms of using these. So if you're going to use one that's applicable to your population, you need to continue using that and using the growth charts to follow obesity in that particular chart. So obesity is fairly common in our region. These data are using different measures of obesity, different cut points. But what they do show is that the prevalence of obesity, total obesity, you can see Kuwait has got one of the highest in the region, followed by Qatar, Saudi Arabia, UAE, Bahrain, and Oman. But I want to also point out here that boys in blue have got higher prevalence of obesity compared to girls. This is opposite to what happens in adults. In adults, women have got higher prevalence of obesity than men. So in children and adolescents, a different story. So the genders are reversed. These are data from the Qatar measurement program that happens by the Ministry of Public Health. And as you can see, about 21.5% overall have got obesity, and 21.2% have got overweight. Here again, you can see that it's more common in boys than girls, and is also more prevalent in terms of obesity in Qataris compared to non-Qataris. And what about compared to the rest of the world? As you can see, with overweight and obesity together in children being 42.7%, this is comparable to the USA, but higher than New Zealand, UK, and global average prevalence. So you can see this is fairly high in Qatar. If you project what's going to happen in the future, this line presents in 2030, on average, the Gulf countries will have about 24% prevalence of obesity, but I expect that will be much higher because this used data that were older. And as you can see, Kuwait is projected to be highest and followed by Qatar, UAE, etc. Here you can see the Pacific Islanders, children and adolescents in the Pacific Island, because they're ethnicity, and various environmental factors and genetics have got some of the highest prevalence of obesity in the world. What about complication of obesity? There are over 200 complications of obesity, and I'll point out some of these for you. In terms of neurological, there's raised intracranial hypertension that results in headache. There are problems with vision. Obesity affects hearing and can result in hearing loss in adolescents and adults. It's also associated with the increased prevalence of multiple sclerosis and several autoimmune diseases that happen that are increasing in prevalence that are driven by obesity. Dental cavities and periodontal disease, and it's not unusual to have children who've got very severe tooth decay and gum disease. In terms of cardiovascular, which is what we worry about, they have hypertension, which is non-dipping, because when you go to sleep, your blood pressure dips, but if it doesn't dip, that means it has an increased cardiovascular risk. And this is observed in adolescents. It results in dyslipidemia, endothelial dysfunction, and left ventricular hypertrophy that can progress to heart failure. Asthma is very common and it's increasing in prevalence as the relationship between asthma and obesity. And it's not unusual to find children with obesity being given inhalers to take when the obesity is actually driving the airway obstruction. Sleep disordered breathing is a problem of stopping breathing at night, and hypoxemia that results in wakefulness that is not perceived by the individual that drives hypertension. So these children stop breathing at night multiple times and become hypoxemic. That results in hypertension, as well as increased risk of cardiovascular disease and sleepiness during the day in some children, but also hyperactivity in other children. So many children are misdiagnosed with ADD, attention deficit disorder, when they actually have sleep apnea. Of course, impaired exercise tolerance, and now we have COVID, and we know that both children and adults with obesity tend to have worse viral infection and with more requirements of intensive care, and mortality is higher in adults with obesity who contract COVID. Hyperventilation syndrome is more severe when there's carbon dioxide retention as well as hypoxemia and relationship with heart failure. Of course, physical function is affected. The children, as you saw in Aisha, was tired, didn't have mobility, had reduced physical activity level and also quality of life. There's glucose intolerance resulting in diabetes, polycystic ovarian syndrome that results in abnormal menstrual cycles, and hirsutism. Puberty can be delayed or accelerated. Usually is accelerated in girls and delayed in boys. Metabolic syndrome, type 2 diabetes, and boys are particularly affected by gynecomastia, and they find it very embarrassing. That affects their self-esteem and quality of life. There are skin changes, including increased risk of psoriasis and fungal infections. Psychosocially, reduced self-esteem and depression and anxiety are common in children affected by obesity, which can also be related to disordered eating habits and dissatisfaction with body image. Obesity is one of the drivers of kidney disease and can also result in enuresis. Looking at musculoskeletal problems, there's acute pain, there's increased risk of injuries because children with obesity tend to have gait disturbances and lack of problems with balance. There's postural misalignment, and they can end up having fractures. An emerging disease is fatty liver disease. That's one of the major causes of cirrhosis, but we don't really know what the lifespan, what the natural etiology, pathogenesis of fatty liver disease in children. So that's important to follow. They get acid reflux disease. It's associated with increased inflammatory bowel disease as well. And cancer, acute lymphoblastic leukemia, is much more common in children with obesity compared to adults. And as children and adolescents with obesity, 70% of those with childhood obesity end up being obese adults, ending to develop early premature coronary artery disease Many cancers, which are very common, colon cancer, breast cancer, are associated with obesity. There's problems in fertility, as you saw in Aisha's story, osteoarthritis, type 2 diabetes, and of course, adult obesity we talked about. We have to worry about weight stigma. It's very common, and it's important to know that we as healthcare professionals, we need to be, and societal members need to appreciate this. So weight stigma is a societal devaluation of a person because of overweight and obesity, and negative stereotypes. And many people think that people with obesity have got no willpower, they're lazy, they lack motivation. And, Aisha didn't decide to become obese. It wasn't her plan, but it just crept up on her, and it wasn't because of willpower. And every time she attempted to lose weight, she couldn't keep it going because she didn't have the right support. As children, there's teasing, bullying, and victimization, and it's very common in schools. That results in poor peer relations and bullying and poor performance at school. And eventually, obesity reduces chances of employment, career progression, and earnings. So weight-based stigma often stops people undertaking physical activity because they don't want to go out there, they don't want to participate in sports and team-based sports because of how they look, and they're worried about how they look and how people will perceive them. And many healthcare professionals have got negative attitudes towards people with obesity. And I said, well, actually, it's your weight that's your fault, and you don't have any willpower to be able to address this. And many facilities are not equipped to care for people with obesity. Weight stigma by itself can result in binge eating, mental health disorders, depression in particular, impaired social development, problems with education and performance, and can be also associated with self-harm and suicidality. So we need to think about the attitudes towards obesity. It's not a choice, it's a chronic disease. And we have to think about our assumptions that we make about people and really change our language as we talk to people and children in particular with obesity, because they're going to be affected for a long time. So think about the language we use and also the pictures. It's not uncommon to see photos of obese obese photos, they call, rather than people with obesity, making people look bad as if they're eating the wrong foods or not exercising and these kind of things. And providing them with holistic care and think about that person's attitudes about what's happened to them in terms of their weight. So it's important to take that into account. So in terms of what causes obesity, there are individual non-modifiable factors. Of course, we can't change our genetics. I'm going to talk about epigenetics in a minute. So you can't change our ethnicity and we can't change our gender. As you could see, it was more common in girls in childhood than boys. And in certain ethnicities, I showed you the Pacific Islanders, for example, we've got higher risk. So the genetics, we've got monogenic obesity, we have polygenic obesity, and syndromic obesity. So if you look at monogenic obesity, it has a high genetic contribution because a single gene that's affected compared to polygenic where multiple genes are affected. Usually the single genes are recessive. That means there's consanguinity involved. The two recessive genes have to get together from the parents to result in that monogenic disorder. Whereas there are multiple different genes that are affected in polygenic obesity with over 1,100 loci affected, and major parts of non-coding regions or between genes rather than the genes themselves. And the most common gene that's associated with obesity in polygenic is FTO, which results in about 4 kilos. These have very small effects. So FTO, which is the strongest effect, is about 4 kilos. So each of these genes in polygenic disorder are contributing small amounts to result in obesity, whereas monogenic, single gene has a large effect. Obesity is polygenic, it's common, and monogenic is rare. It's high penetrance. I mean, you will see the phenotype more likely, whereas low penetrance in the polygenic, and the environmental effect is very low, but the environmental effect becomes higher in the polygenic obesity. So most of appetite regulation occurs in the hypothalamus, and many of the important monogenic disorders are affecting the system. So there's an area called the arcuate nucleus that has neuropeptide Y HERP neurons that project to the paraventricular nucleus. that are associated with increased food intake, and there are POMC neurons here that also project to the same area that actually inhibit appetite. So leptin is released by fat cells, so there are too many fat cells. So leptin inhibits the AGRP neurons while it stimulates the POMC neurons, so it's signaling reduced appetite. So leptin acts through the arcuate nucleus through the leptin receptors, leptin RB, and inhibit AGRP neurons and inhibit the MC4 receptors, which are important in terms of appetite suppression. So once you inhibit the MC4 neurons, then people eat, increase their food intake, and animals increase their food intake. But leptin also acts through the POMC neurons, and the POMC neurons stimulate the melanocortin 4 receptor, and that results in reduced food intake. So this is how the major appetite regulation occurs in terms of monogenic disorders. And if you look at POMC, for example, there's an enzyme that breaks it down into different active parts. So there's pro-hormone convertase enzyme that basically results in ACTH production, which is important in adrenal function. So ACTH acts on adrenal glands to produce cortisol, but alpha MSH is the main component that's involved in terms of appetite suppression. So alpha MSH then acts on the MC4 receptor to result in reduced food intake, but also peripherally acts on the MC1 receptor, which results in pigmentation of the skin. So if there's a problem in this system, there's differences in pigmentation. So leptin is a 167 amino acids, 16 kilodalton secreted protein. It's produced by fat cells, and it's related to fat mass. So the more fat mass there is, the higher the leptin. But which means that actually leptin should be signaling in humans that you shouldn't be eating, but actually it doesn't get into the brain when it's at high levels to tell you to stop eating. So leptin is much more important when there's starvation. So during starvation, leptin levels are low, which is signaling starvation, which reduces the POMC neuron firing and increases the AGRP neuron firing, which results in increased food intake. In rodents, if there's mutation of the OB gene, which is a leptin gene, that results in obesity in mice. If there's a mutation of the DB gene, which is the leptin receptor, that means leptin is not working, that results in obesity. Zucker rats have got abnormality in leptin receptor signaling that results in obesity in Zucker rats. We now have human mutations in both leptin and leptin receptor genes that are associated with obesity, and have been described. The next gene of importance is the melanocortin 4 receptor, which is the key in terms of AGRP and alpha MSH axis, the most common single gene defect, which results in hyperphagia and obesity. It is pathogenic in about 5% of severe childhood obesity. But interestingly, up to 0.3% of general population also have this problem. It's one of the commonest monogenic genes known. And it also not only affects your food intake, but also your preference for fat. POMC is important, and if there's POMC gene mutation, that results in adrenal insufficiency because there's no ACTH to act on adrenal gland to produce cortisol. Of course, because there's no effect on the MC1 receptor, that results in red hair. So these individuals will not only have obesity, but they will have adrenal insufficiency early on in childhood, and will need cortisol replacement and will have red hair. As you can see, these are many genes that are individual genes that are affected, but just to point out, they're either affecting the MC4R receptor, something that the MC4R receptor is not working, or is affecting the POMC. So that means there's no alpha MSH signal within the hypothalamus to reduce food intake. So many of these genes are acting through that system, the monogenic disorders. And you can read up about them in more detail. So leptin gene mutations, we can treat them by giving recombinant leptin. So if there's no leptin, we can replace leptin. If there's leptin receptor or POMC mutations, what are available currently are selective melanocortin 4 agonists. I mean, they stimulate the melanocortin 4 receptor to reduce appetite. So in POMC deficiency, these melanocortin receptor agonists, if you treat them in phase 3 trials, you will see an average weight loss of 25.6%, with 80% achieving more than 10% weight loss. And those with the leptin receptor mutations, because what you're doing is acting downstream of leptin, the effect is not as great. So you get a weight loss average of about 12.5%, with 45% achieving more than 10% weight loss. So these drugs are effective for these particular mutations, and it's gratifying that we now have treatments directly or indirectly helping these mutations. Let's look at how the brain controls appetite. So we have the homeostatic system, which is your hypothalamus. And this hypothalamus not only receives signals from leptin, but also from the gut. So glucagon-like peptide 1 is released and PYY are released by the gut, and they both inhibit appetite. So does oxyntomodulin, pancreatic polypeptide, and amylin. So these all increase satiety, and ghrelin is released by the stomach that increases hunger. And then we have the hedonic eating, which is eating for pleasure. And this is mainly through the dopamine system and controls wanting and motivation and drive to eat. And opioid and cannabinoid receptors control liking and pleasure for food. And then we also have the executive function, which is our decision-making system for eating, whether we eat a particular food or not. But actually, most of the genes that are actually affecting in polygenic obesity, which is your common obesity, affect the homeostatic and hedonic system. So 70% of our appetite regulation of decisions that are made below the cortex are affected by polygenic obesity, and we can't really change that. So many individuals are already destined to have problems with obesity because of their genetics. So there's syndromic obesity as well, there's complex set of genes that are affected. So in Prader-Willi syndrome, which affects 1 in 20,000 to 25,000 births, there's absence of the paternal chromosome 15q11 to q13, and they're born with hypotonia. They end up having intellectual disability. They're hyperphagic. These are the children who you have to really lock the food cabinets because they're always hungry and always eating. There's hypergonadism, and their behavior problems such as temper tantrums. And they also have a compulsive feature. Others are Bardet-Biedl syndrome, and Alström syndrome, and trisomy 21. So each of these are multiple syndromes that are associated with obesity, but they tend to have a complex phenotype with other features that can identify what the problem is. Let's talk about epigenetics. This is fairly complex. So Aisha was born to a mother who had problems with obesity, and Aisha had problems with gestational diabetes. So her daughter ended up having obesity, couldn't give her a kidney transplant because of that. So this is epigenetics. That means the intrauterine environment is really key. So there's maternal undernutrition, or there's micronutrient deficiency, or there's paternal diet issues or other exposure. There's maternal dysglycemia, which is gestational diabetes. There's placental dysfunction or reserves. What they do is they basically affect the intrauterine environment, and that means they switch genes on that increase appetite and reduce energy expenditure, and they switch genes on that switch genes off that decrease appetite and increase energy expenditure. So the baby ends up being small for gestational age, large for gestational age, and if they're small, there's catch-up growth and adiposity rebound. So by the time you're born, the number of fat cells are set in the body, the beta cell number and this functionality is set, the number of muscle mass and muscle insulin sensitivity is set, the liver function is set, the neuroendocrine circuitry that tells you to eat and not to eat and affect your energy expenditure is set, and inflammatory response is already set. And then you add the lifestyle factors into that, and you end up having obesity in childhood that progresses then to obesity in adulthood. So this is a vicious cycle, as you saw with Aisha's life, that results in obesity begetting obesity and begetting obesity as we go across generations. So in terms of genetics, Um, it tells us that individuals gain and lose weight differently from others. That's very obvious, and that's genetics. Some people's appetite is different from others. Some people's energy expenditure is different, and that's all set by genes and epigenetics. So appetite and hunger are different. Hedonic responses are different. I like certain foods. Other people like different foods, and this is affected by genetics. Our energy expenditure is different. Our risk and response can be estimated. So if you have certain particular genes that are affected, then we can potentially estimate how at risk a child is, for example, to developing obesity in the long term, and eventually be able to say who's going to respond to which treatment or not. But genetics cannot be changed, but we have to manage the problem. So let's look at the environmental factors that are associated with obesity. So in terms of the individual, apart from the genetics, the environment is very important because our genetics haven't changed over the years, but our ancestors are species dependent on obesity because we need to keep as much energy as we can to survive as species. But the environment has changed dramatically to result in obesity on top of the genetic risk. So there's a famous obesity researcher called George Bray, who said basically genes load the gun and the environment pulls the trigger. So in terms of individual knowledge, attitudes and beliefs and preferences with regard to weight-related behaviors are important. Self-efficacy, whether people are able to make decisions and be able to manage their obesity that way. Body image and psychosocial health is important. Stress, anxiety, mental health, and some medications result in obesity. The family environment is important. Socioeconomic status in some countries, having higher socioeconomic status is related to obesity, whereas in others, it's lower socioeconomic groups who are affected by obesity. The family dynamics is important. Parental behavior. So if there's obesity in parents, not only genetic, but also behavior, that also drives the whole family of how they behave. We know that breastfeeding is preventive and can be protective against obesity. And actually, Qatar has got some of the lowest breastfeeding prevalence in the region. Non-responsive feeding, that means forcing a child to eat when they're not hungry, is associated with obesity. You must finish your plate, you must clean your plate, you must eat now. Sibling behavior is important. So if your siblings have obesity, they're more likely and behave to order food, for example, from Talabat all the time. That affects how the child behaves. Parent and sibling knowledge, attitudes, beliefs, and preferences are important. And family feeding and parenting practices. So if the family eats in front of TV all the time, so you associate sitting in front of TV with always eating all the time. So instead of sitting at the table and eating. The school environment is important as what food is provided. And increasingly, I have sadly to say that physical activity in schools has diminished over the years. The feedback from peers are important. So there's a trend to actually say, it doesn't really matter if you have obesity, problems with obesity. So acceptance is also a problem in terms of peers, as well as stigma and bullying and teasing. Family engagement in school is important. Weight stigma and bullying we've already talked about. And in terms of community, if there are no safe recreation spaces, people are not going to go out. Many of the complaints here is that, well, it's too hard if you go out there. There's not enough access to pavements to be able to have safe physical activity. So walkable neighborhoods are important. So the built environment is absolutely important. Access to public transport rather than using cars all the time. And now there's food is available 24/7, and children have got access to many apps that allow them to order food independently of the parents at any time of the day. Fast food restaurants are increasing, particularly in Doha, in Qatar. Food marketing is important. Advertising is very big in terms of making children want to eat the wrong kinds of food. If you look at any cereal packet that's unhealthy, you will see that it's really got cartoons and freebies and things that are given to children in terms of encouraging taking these foods. access to care. So Aisha didn't have that much access to care when she was a child. So there's poor access to good care and holistic care to be able to address this. And social media has become very strong in terms of promoting unhealthy food intake, as well as changing our cultural dynamics towards our attitudes towards what we eat and whether we undertake physical activity or not.
Dr. Shahrat, are you okay to take some questions now, or would you prefer to take them at the end?
I can take some questions now.
Okay, so Dr. Alat's question is, in terms of the mode of birth delivery, is C-section associated with a higher risk of childhood obesity compared to natural birth?
There are some data to suggest this cesarean section is associated with increased obesity, but it's not as concrete as we would like, which means that actually the rates of cesarean section have gone up over the years. And this is because of also followed with obesity, because obesity can result in birth complications. So many women with obesity end up having cesarean sections, which makes recovery very difficult and can beget obesity in childhood. But it's very difficult to tease cesarean versus normal vaginal delivery, because what happens is usually obese women who have the cesarean section, so they tend to have obese children. So it's very hard to disengage the two.
Thank you. The next question was, you mentioned a number of syndromes that may be linked to obesity, one of which was the Prader-Willi syndrome, and you mentioned some other syndromes. What's the prevalence of those syndromes locally, if you're aware?
They're fairly rare. This is not very common. So most syndromic, obviously, the most common one that I mentioned, that was trisomy 21, which is Down syndrome. So that tends to be more common in the local population compared to Prader-Willi and Bardet-Biedl and Alström syndrome. And each of them have got different issues. So for example, Alström syndrome is associated with problems with hearing loss and particular phenotypes. But if there's a particular phenotype to that child, then we do recommend genetic investigations to look at the syndromic effect.
Thank you. And you mentioned some drug classes that are emerging, one of which was the POMC, one of which to treat the POMC deficiency. So the question is regarding how close are we to seeing those drugs on the market?
So the drug for POMC is approved by the FDA, so it's available. So POMC mutation is called setmelanotide. And it was shown, I showed you the data from the phase 3 trials. It's very effective for those who have problems with either leptin receptor mutations or POMC function, and they act as agonists. They may be important in other childhood obesity, but this hasn't been tested yet.
Okay, thank you. And the final question before we move on is, can you elaborate on the role of parents in childhood obesity, including constructing a supportive environment?
Well, I could speak for hours on the role of parents. So parents are absolutely important. First of all, as we discussed, the epigenetic background. So if you have one parent who has obesity, then you're more likely to have a child that has obesity. If you have two parents that have obesity, they're even more likely to have obesity. And this is not only genetic, but also epigenetic, but also environmental. So if the parents are not engaged in terms of healthy behaviors, then the children are not likely to have healthy behaviors either. So and it starts very early on. So there's no breastfeeding. There's like I said, getting children to eat when they're not hungry, so they have no concept of satiety. So parents are important. So they're the key to the many measures of childhood obesity. And when they come to clinic, unless the parents are engaged, it's very difficult to manage the child.
Okay, thank you. I think we'll save the remaining questions for later on in the presentation.
So the lifestyle factors that are contributing to obesity are sedentariness. So increasingly we're living sedentary lives. So if you talk about Europe, the children used to play in the streets, and now they're playing video games and not engaging at all with any activity. So screen time has increased. many children and adolescents have now access to iPhones and iPads and Samsung phones and mobile devices that are being used, and they're being exposed to it at a very, very early age. And in fact, the WHO recommends, and many guidelines now recommend screen time for children at a very early age, and managing screen time. Exercise frequency, intensity, type, and time. So exercise, lack of actual exercise rather than sedentariness, and daily physical activity contribute to obesity. It's very sad that physical education has gone downhill in schools and is not provided. Our diets have changed. We have higher portion sizes. Processed foods are very important. So there's a study where they brought people, young adults, into the lab, and they gave them processed foods, and not only increased their food intake, but it resulted in weight gain. So processed foods are things that we buy that are actually further away from natural food, whether the food has been processed, added, frozen, whatever it is. And many of our foods are processed these days. And Qatar is particularly worrisome when the food is imported, because many of the foods here are imported and tend to be processed for preservation. Skipping breakfast has been associated with obesity, but there are many individuals who don't eat breakfast, so there's not always a consistent effect. The things that what we call endocrine disruptors, certain foods that actually disrupt endocrine function, or certain packaging in the food that affects allows disruptors to get into our system that affect our endocrine management. Fast food is greatly available, and sugar sweetened beverages, which has been a target now for many governments through taxation. So sugar sweetened beverages have got a relationship with obesity, and many governments, including Qatar, what they're doing is basically taxing sugar sweetened beverages, but the effect is going to take a while to show. But in Saudi, which was one of the first countries in the region to have taxation of sugar sweetened beverages, actually the sugar sweetened beverage consumption has gone down. Fruit and vegetable intake is important. Children are eating less fruit and vegetables, and this is again through the story of Aisha. Dairy intake can be associated with either obesity or reduce obesity. So the jury is out on that. Of course, glycemic load, foods that release sugar quickly and greatly, are associated with obesity. Sleep is emerging as an important factor. So sleep duration, sleep quality, poor sleep schedules, napping and screen time that affect sleep are also important. I just want to talk a little bit about diet. So diet intervention have to be delivered by a specialist dietitian who's interested in that age group and has got experience in that age group. Adolescents are not bigger children and are not grown up, so adults, so they have to be managed separately because they want to have their autonomy to be able to make decisions. And the aim could be weight maintenance in the clinic. So we're hoping in some individuals that we stop them getting further problems with weight, and eventually they will grow so that the weight matches their height, or we can achieve weight loss. And usually this is done through energy restriction, and diet is dependent on the individual preferences and the ability to cope with them. So there's no specific diet that's the magic diet that works for children. It has to be reduced energy intake, but it has to be healthy and within the national guidelines in terms of healthy food provision, but they reduce energy intake. So this is a group of primary school children that we measured sort of activity levels. You can see sedentary activity. Let's just look at this baseline. You will see that actually only about 50% are taking 40% are taking moderate activity. The majority are sedentary. So primary school children should not be sedentary. They should be running around doing things and being very active. And this group in Qatar, what we observed, I will show you here, that this BMI Z score, which is a standard deviation score of BMI, is related to sleep time. So the shorter the sleep time, the higher the BMI Z score, the higher the waist circumference, the higher the fat percent, and the higher the fat mass. So in primary school, children's sleep seems to be highly correlated in terms of adiposity, so in primary school children. And let me show you what sleep looks like. So sleep is this green area here. So this is a UK adolescent. You can see it's very boring, goes to bed at the same time, wakes up at the same time. This is sleep in Qatar on your right. You can see how haphazard sleep is in Qatar. So one of the areas that we're interested in is to be able to fix sleep in children, and maybe help make a contribution in terms of obesity in children in Qatar. So we need to understand the biology of obesity, because unless we understand the biology, we won't be able to treat it right. So when weight loss occurs, the body senses this energy loss, and our body is designed to keep fat and keep energy. And what happens is the body reduces metabolism, so weight loss will slow down. And if you stop doing what you were doing before in terms of diet or activity, then the weight regain occurs. And also hunger and appetite increases as well when there's energy deficit, and that all results in weight regain. So this is the problem with chronicity of obesity, is that once we start losing weight, or a child starts losing weight, there are defense mechanisms that will bring that weight back. And this is where medication and behavior comes in to stop that weight regain. But unfortunately, there are very few medications that are available in children, because nobody wants to do the trials. The drug companies are reluctant to do trials in children unless they have monogenic obesity, like I mentioned. So we're left with behavior change to be able to do that, and that's very difficult to do, particularly when the child is growing and changing attitudes, and there's no parental support. So how do we treat children and adolescents with obesity? It has to be multi-professional, because as I showed you, there are multiple complications of obesity, which means that if you identify something to do, for example, with cardiovascular system like hypertension, we may need to involve, or heart disease, we may need to involve cardiologists. If there's diabetes, we need to involve endocrinologists. And it has to be multidisciplinary. That means we have to address the issues that are important, which are diet. So we need a specialist dietitian, we need specialist nurses, we need psychological support, which are important for both the individual and the family. And we need physicians to be able to address all that. And sometimes we need social workers to be involved in that, and the extended community as well. It has to be personalized to the age of the child, the gender of the child, the severity of obesity, what are the causes. I describe obesity is a little bit like Hamad International Airport. Every child arrives at it from a different angle, so we need to find out where they came from, what's the dynamics in the family, what's the background, what's the culture, what's the socioeconomic status, how do we fix all that? We need to look at the complications and the family circumstances. It has to be family orientated, because unless the family is working as a unit, you're not going to succeed. So a child who's really attempting to control his or her weight can be affected by the sibling who always brings food to the family, or orders food, or buys chocolate, or whatever it is. And our focus should be on health. We don't want to focus purely on weight, because weight is a symptom of the problem. And weight loss, if we become too focused on that, then that can result in poor self-esteem and eating disorders. So we need to talk about health rather than the weight. We frequently focus on the scales, whereas we need to talk about health. And a child, even though they may not have lost weight, they may have changed the quality of their diet, they may have increased their physical activity. So those are all very positive things that we can focus on. So in terms of weight loss, if we're going to look at successful outcome, we looked at sort of degree of BMI reduction. But that degree of BMI reduction that reduces complications of obesity is not well known. But generally, it's believed that BMI Z score reduction of 0.25 and to 0.5 may be clinically beneficial, but we just don't know, because nobody has done a long-term study of reducing in a multidisciplinary way and seeing what the outcome is going to be. The objective could be weight maintenance, as I mentioned, or weight loss, depending on the complications, and then we need to manage the complications such as diabetes, if it's present, hypertension, dyslipidemia. So all these things we need to think about managing. And in terms of diet, so a specialist dietitian will spend a lot of time improving diet quality, and that's really important. That means avoiding processed foods and concentrating mainly on healthy, nutritious food, as the guidelines recommend, at least 5 portions of fruit and vegetables a day. And the idea is to reduce energy-dense, nutrient-poor foods, crisps and chocolate and cakes and these kind of things that are used actually to sadly reward children rather than actually giving them nutritious food. Reduction of sugar sweetened beverages is an approach. Improving dietary behavior, so having regular mealtime routines, making sure the family eats together, and there's no unnecessary snacking between meals, but there's healthy snacks available should the child be hungry, physically hungry rather than emotionally hungry during that time. Reducing fast food intake, as well as stopping using food as reward, because that's really important, because frequently we say, oh, if you're good, I'll give you some chocolate. If you're good, I'll take you to the cinema and I'll buy you popcorn and hot dog and all these things. So this is what has to be avoided, and actually use non-food rewards. And actually one of the rewards could be spending time with your child together. It's quality time and doing things together and paying attention and being there with them, which is very beneficial. So in terms of physical activity and sleep, we need to individualize by understanding what the capabilities of that individual, their social circumstance, their access to physical activity. But our initial focus is to reduce sedentary behaviors on screen time, and getting the children and adolescents to focus more on other activity and getting around. Exercise can be supervised or unsupervised. Better success with supervised, because actually the children are there, they're being supervised and things are being done, and that the exercise regimen follows the FIT principle, which is frequency, intensity, type, and time. And the recommendation varies depending on the guideline, but over 60 minutes for at least 3 days. So that's what it's aimed for. It has to be graded, has to be enjoyable, otherwise the child or adolescent is not going to do it. And repeatable. That means you have to be able to access it throughout the year. So some things may not be possible to access throughout the year. In terms of sleep, having regular sleep schedules are important. Avoiding use of mobile phones and things in the bedroom is key. Having a dark, cool room that's free of noise is important. So it's very common for children to have disturbed sleep because everybody's partying outside. All the adults are making noise. So they have to be aware of how they manage that. In adolescence, caffeine intake can result in disturbed sleep. So we don't recommend caffeine if the adolescent's drinking caffeine, to avoid that near bedtime. So if their bedtime is 10 o'clock, we say at least leave about 4 hours before, and don't take any caffeine after 6 p.m. In terms of behavior support, we follow goal setting. So we work in terms of building steps. So a journey of 1,000 miles starts with 1 step. So we start with very small steps. So if you imagine if a child is doing no activity and hates activity, so we can start with 1 minute a week and increase 1 minute a week. So by 45 weeks, they'll be doing 45 minutes. By 60 weeks, they'll be doing 60 minutes a day. So if you can start very small, and people don't realize that actually this can build up over time to be actually important. Stimulus control is important. So every time I'm sitting in front of the TV, I eat. So we need to change that signal, break that cue that TV means food, or talking to my friends on social media means food. Monitoring is important. Also developing some kind of gamification to get children to monitor their activity levels, number of steps taken. There was a study carried out in Bristol University where they looked at something called a mandometer, where they actually weighed the food while the adolescent was eating, and it slowed down the eating and resulted in some weight loss. So slowing down eating by monitoring how quickly and how many times food is chewed makes a difference. Paying attention to eating disorders is important, and eating disorders can be sometimes related to child abuse, and child abuse can occur, so we need to be aware of that, and that can happen within the family. So we need to find out about the dynamics of how that's going to affect. So we've had adolescents, for example, who said, actually, I want to keep this body shape, and that's why I'm eating, because I do not want to be harassed by family members or abused by them. So that's important. We use CBT and acceptance commitment therapy. That means accepting how you're feeling at that time, or what your reactions are, to be able to address that behavior pathway towards a certain behavior. So I feel sort of depressed, so I'd eat, or I feel sad because I eat, or I'm anxious because I eat. So acknowledging that and finding other ways to deal with anxiety and sadness. What about medications? Unfortunately, as I said, there are very few medications to help children with obesity and adolescents. So metformin can be used for weight management, but it doesn't result in major weight loss. And because most of the trials have been done by the drug alone, whereas never with the multidisciplinary team. Sometimes when it's used with a multidisciplinary team, we get better results with metformin. All is that, and metformin, the way it works is manifold, and it's not because it's a diabetes drug, but what it does is actually increases a hormone called GDF15, and GDF15 is an appetite suppressant, and GDF15s are elevated in early pregnancy. That causes a nausea feeling in early pregnancy. So metformin works through reducing appetite. Orlistat inhibits the pancreatic lipase enzyme, so stops absorption of fat, but the individual has to be on a low-fat diet, otherwise they will have side effects of diarrhea, which is unpleasant for an adolescent to have. And these drugs are usually used for children who are 10 to 12 years old or older. GLP-1 receptor agonist. So GLP-1 is a hormone, glucagon-like peptide 1, that's released by the small and large intestine, signals appetite reduction in the hypothalamus. So these drugs are available now. So GLP-1 usually has a half-life of about 2 minutes in the blood. So longer acting forms have been developed that are given as daily injections or weekly injections. Currently, for those who are 12 to 18 years old, there's GLP-1 agonist, receptor agonist that has been approved, and that showed basically 43% achieved a 5% weight loss, which is believed to be a significant, clinically significant weight loss compared to 18.7 placebo, and 10% weight loss was achieved by about a third of those individuals taking GLP-1. And this drug is now approved within the Gulf as well, so it's available to adolescents for weight management. The main side effects of the drug are nausea and vomiting, because that initially affects GLP-1 reduces gastric emptying. That's the initial effect, but then the secondary effect is the brain reducing appetite. This initial nausea and vomiting gets better over time. We may give treatments to reduce nausea and vomiting during that time until the adolescent gets used to the treatment. Again, nothing works without multidisciplinary care and changes in diet, physical activity, and behavior. There are endoscopic procedures that have been used in adolescents using gastric balloon, but this is a very short-term approach, and it's a balloon that sits in the stomach for about 6 months. and basically is taken out and results in about 10 to 15% weight loss. And with bariatric surgery can be used in adolescents who've got quite severe complications, diabetes or the worries in terms of their health. So it can be a consideration for these individuals. So here's a national clinical guideline. It's about to be renewed, actually, hopefully in 2022, but I expect it will be 2023 before it's renewed. Just to highlight to you what the CATA guidelines say, decisions have to be made together with the child and their family. That's really important. Comorbidities, we don't call them comorbidities anymore, we call them complication of obesity, should be managed and identified. Weight loss before treatment is not mandatory, so you don't have to lose weight to get particular treatments. Provide patients, families, and carers with individually tailored relevant information, so it's about personalization. Tailored clinical care plans important. Encourage parents of children to lose weight if they're also overweight and obese. So the recommendation is parents have got problems with obesity. It's a family problem that needs to be controlled across the board. Pharmacotherapy was not recommended for children under 12 years of age, but guidelines are changing, and there's going to be use of metformin, for example, at a younger age, and then not in overweight, but in obesity. Only orlistat is approved for weight loss, but actually, like I mentioned, there are more drugs now available. Metformin is also recommended for those over 10 years of age, because it has beneficial effects in terms of glycemic control as well as weight. So bariatric surgery, they say it's reserved for sexually immature adolescents, 10 or 4, etc. But the international guidance is changing on that, and actually, provided the individual is mature enough to understand, there's the belief that it's not going to be any harm to consider bariatric surgery in these individuals. A bariatric surgery can be an effective treatment that can be life-changing to reduce stigma, obesity, lack of self-esteem in specific individuals, and can be used. It says last treatment to patient resistant to all interventions. And again, the view is changing on that. It can be provided, can be considered as a primary option if there's the right individual. It's very difficult to change an adolescent whose family all have had bariatric surgery to say to them, actually, you can't get bariatric surgery. Whereas they believe strongly and the family believes strongly that might be the best option for them. Obviously, you need to discuss all the issues with them so they're aware of that. And the main issue that we find is lack of taking vitamins that can result in serious complications, particularly, for example, thiamine deficiencies. There's a lot of vomiting can result in what we call Wernicke-Korsakoff syndrome, which results in early dementia, as well as neuropathy. So it's very serious. So, and adolescents can be notorious about not taking their multivitamins. So surgery endoscopic procedures should only be considered by an MDT. So it has to be in a specialist center who deals with these. So to conclude, obesity prevalence in children and adolescents is not acceptable. It's unacceptable. It's really high. And unless we really address the issue, not only within the individual, the family, the school, the community, and society as a whole, we're going to end up in a serious situation where early obesity results in multiple complications. So these are individuals who are going to look after all of us when we're older, because they're going to bring money into the economy. And after not succeeding in terms of working and developing the economy, then many bad things are going to happen in terms of future survival and as well as success of any economy. So any country that has high prevalence of obesity needs to take that into account. Obesity is a complex disease, and our bodies are designed to keep weight, and 70% of the genes are in our brain that increase our appetite, and many epigenetic factors are out of our control. So no matter how hard we try, it's going to be challenging to address all those, and has serious consequences for the child and the future adults. You saw Aisha's story. It started early on. Aisha didn't want to become obese. It wasn't her intention. She just crept up on her, and before she knew it, she was being given medication that affected her quality of life, and her future. Multi-professional care is necessary. Treatments have to be individualized. You have to understand where that individual is coming to the airport, where they're coming from, where it's going, how do we unravel all that, what's the family dynamics, how they're interacting. Current treatments are insufficient, poorly supported, and people are worried about using medications as well as surgery in younger individuals because they're worried about the long-term consequences. So very limited things that we can do. So what we need to work on very hard is prevention, starting right from the beginning through the built environment, the way our community works, access to food, and the taxation on sugar, sweetened beverages, and processed foods. There's so many different things that we can do. So locally, there will be a Qatar white paper produced about recommendations about how to tackle obesity in Qatar. So that'll be coming out soon. And that's part of the what's called the Open Gulf, which is obesity policy network that's going to talk about how we can tackle it across the Gulf region, which I showed you has got a very high prevalence of obesity. Thank you for listening.
Thank you very much, Dr. Shahadat. It's a really interesting topic and very nicely delivered. Thank you very much in the time that you had available to you. So there's a lot of questions that are coming from the participants. I'm just going to try to ask you the questions that are resonating frequently. So you've put a great emphasis on the need for a multidisciplinary approach to both the prevention and the management of childhood obesity. If I'm looking through the participant list now, we have participants who are less well integrated in the healthcare system, such as community pharmacists, dentists, etc. So how can you, what would you advise their role can be in the prevention and the management of childhood obesity?
Well, I think the first thing to realize is avoid any stigmatizing language, avoid making the weight an issue. That individual or their family may not even be open to weight management. So what we call one of the challenges that people have is raising the issue of obesity with the individual and the family. So that has to be done very sensitively and go from the health point of view in terms of how can we achieve better health for your child, better dental care for your child. So some of the contributors are the kinds of food that child is eating. So they need to think about changing their food habits to reduce dental problems. And same with the pharmacist, is being aware of what drugs could be contributing to obesity. Many children are put on drugs and adolescents are put on medication that affect weight. And sometimes preempting that in terms of thinking about actually this drug is likely to make this child or adolescent put on weight, and how do the parents need to know about that information so they're aware of what they need to do. So they need to see a dietitian to be able to help them in terms of food selection, avoiding those issues. So again, we need to work as a team. Also signposting. So if the parents and the child show willingness in terms of improving their health, then where do they go? We can actually signpost them to the right clinic or the right environment within either primary care or secondary care to be able to advise them about what to do. We're all healthcare professionals. We have to realize we have to have the foresight of what this person's going to be in the future. So I can just deal with a teeth problem and forget about it. A cardiologist can deal with a heart problem and just forget about it. But actually, there's more to it than that. We want to prevent future consequences, and weight is going to end up developing that. So if we can address that issue in a multidisciplinary, multi-professional way, then we can achieve better outcomes.
Thank you very much. I think that really emphasizes the need for all healthcare professionals, therefore, to have a good awareness of the support services that are available locally. The next question, there seems to be a lot of interest in the discussion point regarding the correlation between sleep and childhood obesity. There does tend to be a culture within Qatar that children's sleeping patterns are not from 8 p.m. to 8 a.m. Quite often walking along Lusail or the Corniche, you see children walking around at 11, 12 o'clock at night. and this seems to be quite a common practice. Also, maybe taking naps after school and delaying bedtime sleeping. So could you comment on those behaviours, please?
Okay, so there's a study called Children of the 90s, and children of the 90s recruited 13,000 pregnant women and followed their children up. And now the children are about 30 years old. They asked the question, what is it at age 30 months that predicts a child having obesity at age 7? And they found several factors. So if your parents have obesity, then you're more likely to have obesity. If you're small for gestational age, maternal smoking came up as a factor that drives, and also sleep. The shorter sleep at age 30 months predicted a child becoming obese at age 7. So we've shown longitudinally, prospectively, that actually short sleep duration is associated with obesity, and that has now been shown across multiple populations in the world. What hasn't been shown is actually if it changed sleep, does it affect weight loss or stop prevention? But in public health, many times we have to make decisions that are not necessarily have got any evidence for it. Like, for example, initially taxing sugar-sweetened beverages. We don't know what's going to happen, but it seems a good idea. So sleep is absolutely one of the areas that we can address here in Qatar. And as I just showed you, the sleep is completely haphazard. It's poor quality. It's very disturbed, and it's difficult to manage. So this is where parental education comes in and setting standards very early on in terms of managing that sleep. And sadly, we're living in this 24/7 society that has got lighting and access to various things that distract us. So that's one of the areas that we need to address, educating parents, especially early parents, about children's sleep and managing sleep and making sure that there are regular sleep schedules for both themselves as well as their children, to see whether it will make a difference. I think that's why sleep now has become the third lifestyle factor with diet and physical activity that should be taken into account. We never imagined it when we reported this relationship in 2004 when I first reported it, that actually now it's becoming more and more acceptable that sleep is an area that we need to consider. And sadly to say, it's not just Qatar, but the Gulf region's children have got the same kind of sleep patterns. And because of that, would be one of the reasons we have some of the highest prevalence of obesity in the Gulf countries.
So thank you very much. The next question was, you touched on some of the interventions, specifically the drug interventions that are indicated in childhood obesity. So I think you may have touched on this, but could you maybe just elaborate on the criteria that would make patients eligible for such interventions?
So in terms of criteria, it is basically the CDC criteria or IOTF criteria or WHO criteria that use, and it has to be obesity so greater than 95th centile or 2 standard deviations away, or that needs to be considered as a consideration for obesity. In terms of the GLP-1 analogs, if an adolescent 12 to 18 years old and has a BMI, body mass index of 27 and above with a complication like diabetes or body mass index of 30 and above, it's an indication for treatment. The contraindications for these drugs is a history of pancreatitis, so they can rarely cause acute pancreatitis, so you avoid them unless there's a family history of a rare thyroid cancer called medullary thyroid cancer, because these drugs, GLP-1 analogs, cause medullary thyroid cancer in rats and mice, but not humans. So those are the considerations that need to be taken into account. Obviously, the most effective drugs are the injectable GLP-1s, and the child has to be able to inject that, but that's going to be very hard because the needles involved and many children are needle phobic. That has to be taken into account. Interestingly, we have parents and children and adolescents who are both on the same medication, so that helps sometimes in terms of the outcomes. The main side effects of these drugs are nausea and vomiting, and sometimes diarrhea. And some people feel headaches, but headaches and Dizziness, these kind of symptoms are common with people who lose weight. Occasionally, they can increase the heart rate by 2 or 3 beats per minute, and that can result in palpitation and tachycardia. But otherwise, they've been shown to be fairly safe in adults. And there are cardiovascular outcome trials that show good outcomes in terms of cardiovascular disease prevention. The main question is going to be, how long should they be on this treatment? Is it going to be for life or not? And that's an open question, because as I showed you, it's a chronic disease. So how long would that individual, would they need to be for life or not? That's the big question.
Okay, thank you very much. Okay, so some quick fire questions now. So is there any role for SGLT2 inhibitors? These are the gliflozins in the management of obesity in children.
There are no data regarding obesity management in children. There may be a role in them, but the problem with the SGLT2s are, although they result in weight loss, very modest weight loss, and that's because they make you pass sugar in the urine, so that causes an energy deficit. But what happens to your energy deficit? You become hungry, like I showed you. So you overeat, so you compensate that. So the weight loss is not as great. So maybe a combination of SGLT2 with an appetite suppressant maybe is stronger. In the future, we will see combination treatments coming through, because there are many different pathways involved in obesity, and we need to hit different pathways at different levels to be able to address the weight problem.
Okay, so next question, and I guess this is related to the local context as well, where we see younger people drinking tea and coffee. Would you like to comment on this? Is this a factor that contributes to obesity, do you think, here in the local context?
Yeah, I mean, Carac is a particular problem, and that can result in obesity. But you don't normally just have coffee and tea. You go out somewhere and you have coffee, tea, and cake, coffee, tea, and muffin, coffee, tea, and something. So, and when you go to a coffee shop, usually you have to have eat something with it, and that's going to be one of the challenges. Is there becomes like a treat. Our trip to the coffee shop will involve a chocolate muffin, and that can be a reward for you for being good or achieving good results at your school. But why not give a non-food reward, like a trip or family time, or doing something different, or a bike or shoes or something that the child can actually find beneficial.
Thank you. You've touched on some of the public health initiatives that have been introduced in Qatar. One was the sugar taxation. Can you maybe discuss some of the other strategies that have been launched, and maybe if you can comment on the success of those strategies as well in tackling childhood obesity and encouraging a more active living?
Well, Qatar is particularly paying attention. As you know, there's a lot of construction going on in Qatar, and there's an interest in terms of the built environment. So many of the environments and buildings are being thought with a view of encouraging non-sedentary behaviors and getting people to be moving a lot more. So and making the environment more friendly in terms of not being so hot, so that people are able to actually undertake physical activity. There's been a drive to develop multiple parks and greenery to be able to, particularly in the winter months, to allow people to go walking. The Corniche is being refurbished, so that's going to help in terms of activity. The Ministry of Public Health is working very closely with the WHO to use the World Cup as a background to encourage physical activity and better nutrition. So that'll be of interest as sugar sweetened taxation. But within schools, there's increasing interest in terms of increasing control of what foods are available to children at school, particularly school canteens. So there's recommendations from the ministry about what sort of foods should be available to children and adolescents as they go through school. There's a drive to increase physical activity. I'll show you some of the data which come from the physical measurement program. There's an active physical measurement program that's going on in Qatar that allows all the children to be measured. So there's an idea of what's happening in terms of obesity and its trends, whether it's flattening out or what's happening. So there's lots of initiatives going on, and the outcomes of many may not be known for generations. But it's important to tackle obesity from different angles. And one of the areas that is being addressed, for example, is maternal obesity. So obesity in mothers begetting obesity. So if you can get the mothers to be as healthy as possible, is it possible to stop future epigenetic effects? Breastfeeding, there's interest in terms of pushing breastfeeding as well as prevention of gestational diabetes, which might be driving obesity in the future.
Thank you, Tom. Thank you very much, Dr. Shaharat. Ms. Joyce, was there any questions from your side?
Thank you, Dr. Tahiri, for this informative webinar. I still have one more question concerning as you highlighted, the complications of childhood obesity. Some researchers have showed a negative association between childhood obesity and cognitive development. Can you please, based on your research, if you can elaborate such link?
Well, there are different schools of thought and different data. That's a very good question. But there's this idea that actually people or children with obesity are not performing at school. And there are many studies to show that actually that may not be the case. Actually, they're just as smart as everybody else. There are people with obesity who are adults who are CEOs of companies and are very successful. But there are also some data showing that there's some cognitive deficit that occurs in terms of resulting in poor school performance, and that could be related to various conditions that are associated with obesity. So if a child has asthma, for example, then the school performance may not be as good. If they have sleep apnea, that results in behavior disorders and sleepiness, that can result in poor cognitive performance. We know that children with sleep apnea tend to actually drop IQ points because of this hypoxemia and the brain not getting enough oxygen at night. So that could be one of the drivers of it. But it's important to be aware of what could be contributing to a child not performing at school, whether it's stigma, whether it's teasing, bullying, all these factors come into it that will affect a child performing at school. So it's multifactorial, and awareness of it is really important rather than treating the symptoms of it, treating the ADD, but looking further to see whether there's sleep apnea and then obesity driving the sleep apnea that's underneath that.
Thank you so much, Dr. Tahiri.
You're welcome.
Okay, I think that's all the questions that we've received from our participants. So thank you very much for your questions and being interactive in today's session. I'd like to also thank you, Dr. Tahiri, for the presentation and accepting our invitation. We have had preliminary discussions around having a session in the spring on body image and mental health. So hopefully we can begin planning for that session in the spring. Before we end today's session, I would like to ask if our participants could complete the evaluation. I've shared the link in the text, and it will be available on the events page website. Also, please look at the registration page for future upcoming events. The next event will be the pediatric conference, the first pediatric conference held here within Qatar. So please do look to register if you're available for that conference. I'd like to also apologise once again for the delay in starting today's webinar. We'll look to resolve this issue and look to start the events promptly in the future. Thank you again to all of our participants and Dr. Tahiri and Ms. Joyce, and we look forward to seeing you all again very soon. Thank you very much, everybody.
Well, thank you. We'll see you soon.
Thank you.